Cliff, please. Morning, Cliff.
Morning, everybody. Thank you for joining us this morning to talk about the uplift to the emergency care dataset. So by way of background, the ECDS has been live now for about 18 months and replaced the previous CDS-10 and has made a huge difference to the quality of the data that we're now able to extract from the system increasingly frequently. So we used to get data on a sort of monthly basis with a 6-week lag. With the emergency care data set now, many sites are submitting daily, and most that aren't submitting daily are submitting weekly. And we're getting very high levels, particularly of the diagnosis. This has been brought into sharp relief during the COVID-19 pandemic. And really, we are the only data set. Sorry about that. Somebody's gone on mute now, I think. So we are the only data set that is able to produce almost real-time data, with SAS data being a little bit behind us and HES data clearly being several months behind us. This, therefore, has been an opportunity to leverage the power of high-quality data in terms of both the clinical insights it's brought us and the operational insights it has allowed the system to move forward with. And we therefore in a position that we've been using this data to report to NHS England Board, Simon Stevens and the Secretary of State on a regular basis. We are, however, aware, as always, that the initial versions of a product aren't necessarily as complete as we would wish. And so a key element that we wish to bring to this is the fields that we're going to discuss this morning. They relate to an acuity score using the National Early Warning Score. They relate to the clinical frailty scale, the Rockwood clinical frailty scale, and they relate to one of the metrics that is part of the clinical review of standards, which each of you as field test sites will be fully aware of. So to go through those in a little bit more detail, the clinically ready to proceed time is essential for us to be able to be cited on when patients could move from the ED because their clinical care and initial investigation has been completed in the ED and they no longer need to reside in the ED, but can actually go to a inpatient environment, same-day emergency care unit or ward. Excuse me. This is already clearly a big challenge as the numbers of patients returning after COVID-19 has started to increase and pressure is already building within our emergency departments. And if we are to be able to manage our departments safely and effectively, we really have to be focused on when patients could move from the ED, therefore freeing up the capacity for the next patient so that we do not return to delays in ambulance handover times, and certainly do not return to the idea that we would have patients in corridors, which is clearly always been unacceptable. But in the current climate, it produces a nosocomial infection risk. And we will all be aware of what's happened in Weston-super-Mare recently, and clearly that cannot be allowed to happen elsewhere in the system. So clinically ready to proceed is a metric that you're all familiar with, so I won't labour the point, but we do want to add that actually into the ECDS so that it makes it that much easier for all sites, whether or not they were in the field test site CARDA in the first place, to be able to collect that data. The second item that I'd like to highlight is the News 2 score. Again, all of you will be familiar with this, and we've recently done a survey that shows that this is being collected at most sites, and indeed most sites are also collecting this electronically. So the burden of adoption of this into ECDS should be much diminished. As you can see, this slide already shows that 100% of ambulance trusts are using it and 76% of acute trusts are using it. This is very important in the future for us to be able to make a better case for the resources that are needed to fund our emergency departments. At the moment, we are able to determine, for example, how many patients we see with stroke, how many patients we see with a broken leg, etc., etc. But we're not actually able to distinguish between severe, moderate, and minor easily on the basis of the ECDS data on its own. The NEWS2 score would allow us to differentiate between two hospitals, each of whom see 10 pneumonias, but one hospital, most of the pneumonias are curve 65 scores 0 or 1, and another hospital, the curve 65 scores are 3 or 4. Clearly, there's a massive difference in the severity of the illness and the resources required to attend to those patients in order to treat them. Once we are able to be better sighted on the acuity as well as the diagnostics, we'll be in a much better position to be able to describe the different resources required between one site and the other, both in terms of equipment, drugs, and revenue expenditures such as that, but also in terms of skill mix that we would need to bring to ensure equity of care between one site and another. The NEWS2 score obviously also being collected by the ambulance service and collected increasingly in inpatient units will allow us to map the patient's journey and start to detect important trends for individual patients and patient cohorts in the acuity of their presentation and how that changes over the course of the first few days in hospital and what implication that has for their outcomes. The third new change or addition would be the clinical frailty scale. This is the Rockwood scale, which most people are familiar with and is used widely in the ambulance service already and used widely in many hospitals as part of their comprehensive geriatric assessment tool. Being able to recognise significant frailty at the front door has already been shown in many sites to substantially improve the quality of care we can provide to those patients. And we know already that there's considerable variation in the proportion of patients who present who are likely to be in this category, because we already collect demographic data regarding age of attendance and age of admission. And we know, for example, from the GIRF data that some sites see fewer than 20% of patients, or fewer than 20% of patients they see in their emergency department are over 75, and others that figure is more than 45%. And clearly there's a massive variation in the need to drive these improved frailty services. However, we should not confuse age alone with frailty, and whilst it is a crude proxy for that, it's in no way an adequate proxy for that. And being able to better identify frailty in whatever age of our patient will allow us to target the interventions for that important cohort and hopefully help to decongest our emergency departments at the same time as providing much better services for those patients. So I think that's the slides I was expecting to talk to, Linda, and just to give an overview of why we wish to add them in. We're hoping that this will go to the board next month, and an information standard notice will be issued shortly thereafter, with our plan to implement that as soon as possible. But I will hand over to other speakers to discuss the details of that. Linda.
Yeah, thanks, Cliff. That's really helpful. Just before we move on, does anybody have any burning questions they want to ask at this point? And if not, I think what I'll do is we'll hand over to Mark, I think, briefly, just to give us an overview of how we're going to be using ECDS going forward at central level, and then we'll move on to the other fields. We'll hand over to Tom Hughes, if that's okay. So, Mark, are you okay if I hand over to you for a couple of minutes?
Yeah, no problem, Linda. I'll be very brief because really it's just to echo lots of what Cliff has said. ECDS gives us much richer data analytically for use locally, regionally and nationally, and is obviously essential for the clinical review of standards. We're currently in the frustrating position of having multiple sources of A&E activity data, daily sit rep, the aggregate monthly publication and sus/ECDS. And our vision is that ECDS ultimately becomes the single source of data, which means there'll be less discussion on which is the right figure to be used. There'll be less of a burden on providers, and that data will provide much more analytical insight. We've still got a few challenges in terms of landing ECDS as the sole source because of the data quality and timeliness issues, but we want to work with NHS Digital to support you to address some of those over the coming year. We also intend to start publishing more data from ECDS, which will raise the profile of the data, as well as us being able to draw some insight on items which previously weren't available or weren't in the public domain. So that's all I wanted to say. Thank you, Linda.
Thanks, Mark. And I think Erica has a question that we'll pause for at this point. Erica, can I bring you in?
You can. Thank you very much. It's just a question, I suppose, about system functionality. I don't know the technicalities of our Symphony system incredibly well, but I don't think we currently have provision to capture a frailty score anywhere. So will there be a lead time allowed for supplier development? We're just about to go through an upgrade, so there might be the opportunity to pick it up through there, which I'll check with the supplier. But if not, how does that kind of get factored in? Because systems might not all be set up to kind of capture that at the minute.
Yeah, Erica, the answer to that question is yes, there will be a lead-in time, and I'm going to bring in Pete Sherratt to answer your question about the supplier readiness, etc. Pete, can I bring you in to answer that question, please?
Yeah, thanks, Linda. Yeah, so morning, everyone. My name is Pete Sherratt from NHS Digital, so the lead on ECDS. So that's the reason we're consulting at the moment, is to understand those supplier lead times and also lead times for for implementation from the provider side as well. So please keep yourselves tuned for the release of a survey, which will be in the next sort of week or so for you to fill in, and that will go to providers, that will go to IT suppliers as well, and that'll give us the information that we need.
Thanks, Pete. Did that answer your question, Erica?
It did, thank you.
Lovely, thank you. So, Tom, can I now bring you in, please, to talk about the summary of the ISTV and also the date and timestamp of arrival, please?
So this is something. So, Cliff, if you want to come in on this aspect. So, good morning. My name is Tom Hughes. I'm the ECDS clinical lead, and so this date and timestamp of the scheduled arrival slot, one of the lessons from COVID has been the benefits of integrating different sources of emergency care delivery. And so what this is about is, someone's on mute, please. What this enables is for 111 to be able to book slots in particularly urgent treatment centres, is what the target for this is, so that when a patient rings 111, then they can say, well, you can turn up at this time and you will be seen within a certain time slot. And so it allows a certain amount of planned capacity to be built into the system. So this is just a single date and time, and so from a capture point of view, this will integrate with any diary calendar functions within the product. So it's a discussion which will need consultation with the IT suppliers in order to implement this. Cliff, is there anything more that you want to say on this? You're on mute.
Sorry, you'd have thought I got the hang of it by now. In due course, the importance of the date and timestamp, it's fundamental to our better understanding of same-day emergency care. And one of the challenges we've had is that same-day emergency care is variably recorded using different systems, but that without a timestamp, it's very difficult to distinguish between something that took 24 hours and something that took 6 or 7 hours. So for us, it's particularly important that we understand the time that people arrive and the time that they leave. This obviously it should not be a complex addition to the take up of the product, and really should be largely automated.
Thanks. Shall we move on to the so the assault location description? This relates to the injury sharing to tackle violence data set. And so when we were building ECDS in 2017, then we were looking to integrate the data items from Injury Sharing to Tackle Violence, which is a national program based on the Cardiff model of treating injury and violent injury as a public health nuisance. And so what this does is to collect all key information about patients who attend the emergency department with injuries related to violence. So we integrated successfully most of these. The one outstanding thing that we couldn't integrate into ECDS was the geographical location, so a free text description of the geographical location of where the violence occurred, so outside the dog and duck pub or whatever. And this is something which is integral to the function of ISTV. It makes a great difference to them to be able to accurately locate where these things happen. And so this change is just to allow what is already being collected to be flowed as part of ECDS. And so it's a relatively simple change. The benefit to the system is that it stops there being two data sets effectively, and it will allow integration of the ISTV. So it will actually reduce burden. Linda.
Thanks for that, Tom. Before we move on, has anybody got any questions at this point? And then we'll move on to Pete Sherritt's slide. Okay, nothing in the chat, Pete. So if you want to go on, please.
Yep. Okay. Thanks. So, in terms of things that everybody can do right now, in order to switch on the new version of ECDS, we need to turn off the oldest version because we can only run two versions at the same time. So the oldest version of the schema that's currently in use is called schema 6.2.1. That's the one that we need to turn off, and the new one will be called 6.2.3. We know around about 90 provider sites, so a little bit less than half, are still using 6.2.1. And the actual latest version of the ECDS information standard requires you to be using version 6.2.2. So that's the correct version to be on. And the conformance with that standard was from the 1st of April 2019. So if you're actually still using the older version, you are not compliant with the ECDS information standard, and therefore you need to plan to move to schema version 6.2.2 as soon as possible. Else we won't be able to switch on the most recent version that we need to deploy. In addition to that, the old A&E data set, CDS 10, that's going to be formally retired and completely turned off during 2020, and we're in touch with about 8 sites that are still actually using that data set. So obviously there's a link down below there where you can find the latest information on ECDS.
Thank you, Pete. That's really helpful. So there are a couple of things actually that I kind of want to ask of the people that have joined the call this morning, as predominantly we've got the trial sites for the clinical review standards work that happened. And as part of that, we'd like to gather some case studies. So it doesn't have to be anything comprehensive, just a one side of what your experience was when you did the trial, how you were collecting the ready to proceed fields, what it kind of looked and felt like on the ground a little bit. And by way of that, I thought I might put a template together with a few questions on and send them out to everybody. If you're open to that, it would certainly help out our evidence base for pulling these the ISN into publication later on this year. So just a little bit more about dates. We're hoping to get this published in July, August this year, and we're hoping to be able to start to collect the data from the 1st of January. So as part of that, we're also looking for some early adopter sites that will be able to collect the information and submit the data in January, whilst we're working out what the mandated date will be for collecting the fields. So I will send, off the back of this, I will send everybody an email with a copy of these slides, a link to the recording of the meeting, and just some key questions. And if everybody would kind of respond to that, I'd be really grateful if we can just get some feedback from you when you were collecting the fields. And on that note, does anybody have anything else to say, comment, or any questions? So I've noticed that we're getting some emails through already, which is forming some good discussions about some of the fields. They seem to be very positive, which is a good thing. So what I'll do is collate all of that information and I'll send that on to everybody when I send the slides as well. So Erica has just put a question in the chat. what sort of lead times are we looking at, please? So, Erica, we're thinking that the ISN will probably be published July, August this year, and we'll be looking to submit the data from the 1st of January. As of the mandated date, that's still to be decided, but the ability to record will be from the 1st of January. I don't know if anyone's got anything else they want to add to that. Okay.
Sorry,
Yep.
Linda, just to say that's the current plan.
Yeah.
Depending on,
Yes.
you know, there are outside factors which might come into it as well.
Yes, of course. Yeah. So we've got another call that's a question that's come in, and I'm going to put this one to Pete. So Pete, the question is, will providers still on 6.2.1 have the opportunity to upgrade directly to 6.2.3 rather than 2 upgrades?
Good question. So it is possible to do that. It's probably something that we wouldn't recommend. The reason for that is let's just say the scenario is we switch on 6.2.3 on the 1st of January 2021. Up to that date, you would still be submitting version 6.2.1. And then on the 1st of January, you'd have to do the move kind of, from the transition. If you're maintaining conformance with the standard, which is daily submissions, then you would have to make that transition overnight in theory. But the point being that any delay, any issues with transitioning from one and sort of leapfrogging over the interim version would lead to a dropout in your data flow. So obviously, it can be a fairly complex upgrade. So upgrade being done locally to your IT systems, and then making sure you're sort of cleared to transmit the data through, and you've done all the necessary steps to transfer the data to an HSD. So that's the thing to bear in mind, is that you would be risking dropping out the data for a period, and that would be your risk to manage. But yes, technically that is possible, although not recommended.
Thanks, Pete. Having trouble coming off of mute there. We've had an email through actually from Professor Brian Williams that's been sent around the news with a couple of comments. I wondered, Brian, if you wanted to come in on the chat and have a brief discussion about that, or are you happy for that just to be disseminated by email? I think he might have gone. That's probably why I sent the email. Okay, fair enough. So we've got another question that's come in. This is from Carolyn. Is the time frame giving suppliers 6 months to make the changes? So Pete, another one over to you, please.
Yeah. So broadly speaking, that's the case. That's the kind of minimum time frame that we would expect to give as a lead time for the system to actually make the changes. So the information standard technically applies to the providers. So if there's a 6-month window between the publication of the information standard and the mandatory conformance period, then that requires the suppliers to actually make the changes, and those changes be deployed by the NHS within that 6-month period. So that's the key thing that we're consulting on, is the achievability of that. And the publication of the information standard is regulated by the Data Coordination Board, which is a cross-organisational body. It's part of the Health and Social Care Act, and part of their role is to ensure that an information standard is published with reasonable, achievable timescales. So that's the purpose of the consultation and the assurance that we go through as part of developing the standard.
Great, thanks for that confirmation, Pete. Has anybody else got anything? Go on, Cliff.
It's Cliff. Just one other point I think I'd be keen to make is that we know that there's quite a lot of healthcare inequalities, and people often refer to vulnerable groups and marginalised groups. And I think that the addition of the injury surveillance data is a key way to trying to tackle some of those inequalities in a preventative way, because actually violent crime usually affects men more than women and younger men more than women, and significantly impacts upon the social fabric of society. So it's a particularly important field that we should be proud, I think, to try and introduce and to actually take a lead on. And similarly, the clinical frailty scale, we know that there is considerable inequalities in access to high quality rehabilitation services for the frail elderly around the country. And again, this is another way in which we can highlight that the needs of that particular cohort and do something about it. So I hope that people will see these as very much enhancements to what we can deliver to important cohorts of patients, not simply a data burden.
Thanks, Cliff. That's really helpful. So we haven't had any more questions come in. I haven't had anything else come in by email. So I think we can probably give it another 30 seconds and then we can close the meeting down. And as I said, I'll be sending out all the slides. I'll be sending out a link to the recording of the meeting, and I'll also be sending out a set of questions. It would be really helpful if the guys that took part in the trial could answer those questions for us so we can pull together some brief case studies. If anyone wants any more information, you have our email addresses. We'll also send you an invite to our future collaboration site that's got a host of information on there. And there are lots of useful links in these slides as well that you can refer to. So if that's it, I haven't had anything else come in. So thanks all for coming this morning. I really appreciate your time, and we'll catch you all soon. Thanks, everyone.
Thank you, Linda. Bye-bye.
Thanks. Bye.
Bye, everyone. Thanks.